Welcome to Weekly Neurology Deep Dive. Just a quick reminder, this deep dive is for educational purposes only, and it's really just a summary of recent research. It's definitely not meant to replace reading the full articles. This week, we're going to explore new and current therapies for cluster headaches based on a November 2024 review article called Current and Novel Therapies for Cluster Headache, a narrative review published in Pain Therapy. We're really going to be zeroing in on the key takeaways for neurologists and what they need in their clinical practice, focusing on things like the hard data, the numbers, percentages, recommendations.
Cluster headache is a real beast, sometimes even called suicide headache, because it's such a severe and debilitating primary headache disorder. And unfortunately, it's often misdiagnosed, especially in children, as migraine. We are seeing a rising diagnosis rate among women, though. The prevalence of cluster headache can be as high as 1.3%, with a lifetime prevalence of 0.12%, and it typically starts around age 30.
So for neurologists out there, what would you say is like the most practical information, the need-to-know stuff about how cluster headaches present clinically?
Well, the typical patient, they'll come in with intense unilateral pain, usually centered around the eye, the temple, and the forehead, and this pain can last anywhere from 15 to 180 minutes. And get this, a patient can experience up to 8 attacks every single day. On top of the pain, they're often restless or agitated, and they might have these ipsilateral cranial autonomic symptoms like conjunctival injection, lacrimation, rhinorrhea, or even edema. Now, it's important to remember that there are two subtypes of cluster headache: episodic and chronic. In episodic cluster headache, patients experience attacks in these bouts, these periods of time that last from 7 days to a whole year. The good news is that these bouts are followed by periods of remission that last at least 3 months. But then you have chronic cluster headache, where attacks persist for more than a year, or the remissions are less than 3 months.
So what's actually happening in the brain during one of these cluster headache attacks?
Well, the pathophysiology is pretty complex. It involves a whole network of structures in the brain, including the hypothalamus, the trigeminocervical complex, and a bunch of neuropeptides like calcitonin gene-related peptide, vasoactive intestinal peptide, and pituitary adenylate cyclase activating polypeptide 38, or PACAP38 for short. And all of these are elevated during attacks, which gives us some clues about potential treatment targets.
Which leads us perfectly to the treatment landscape. What are the main goals when you're dealing with a patient who's got cluster headaches?
The main thing we're trying to do is, one, stop the pain right then and there, acutely abort it, and two, prevent future attacks. We also want to manage those autonomic symptoms we talked about and ultimately improve the patient's quality of life.
It's not all about medication, though, is it? Are there any non-pharmacological things neurologists can suggest to their patients?
Patient education is huge. It's so important to empower patients to understand their triggers, like things like alcohol consumption or being at high altitudes. Even simple things like that can make a big difference. Good sleep hygiene is also critical. There's actually a two-way relationship between sleep disorders and cluster headaches. It goes both ways, so encouraging good sleep habits is really important.
So when it comes to treating the acute attacks, what are the most effective options that neurologists can use in their practice?
High-flow oxygen therapy, giving the patient pure oxygen, that's still considered the gold standard for acute cluster headache treatment. It's safe, effective, and works really quickly. Studies suggest that high-flow oxygen, so that's 100% oxygen, delivered at 7 to 15 liters per minute with a non-rebreathing mask, the kind that covers the nose and mouth while the patient is sitting upright, may actually work by inhibiting neuropeptide release and changing the activity in the trigeminocervical complex. Now, one thing to watch out for is that some patients might get rebound headaches after using oxygen.
So are there any other effective options for acute treatment that we should be aware of?
The only triptan that's actually FDA approved for acute cluster headache is subcutaneous sumatriptan. And the maximum dose is 6 milligrams, but no more than 12 milligrams in a 24-hour period. It works really well, and most people tolerate it well, too. Other triptans, like intranasal sumatriptan at a 20 milligram dose and intranasal or oral zolmitriptan, have shown some effects, but they're not as strong, and they're not FDA approved specifically for cluster headache. Just a reminder that triptans are not for everyone. They're definitely contraindicated in patients with vascular diseases, and there's a risk of medication overuse headache and developing a tolerance. Some common side effects include reactions at the injection site and nausea.
What about dihydrogodamine? Is that still commonly used?
Well, it is FDA approved, but the evidence for its effectiveness is a bit limited, and its use has been going down because of the potential risks. It's given as a 1 milligram IV bolus, and it can be repeated after an hour, but the maximum is 3 milligrams in a 24-hour period and no more than 6 milligrams a week. Also important to note that it's contraindicated during pregnancy, and it shouldn't be used within 24 hours of taking a triptan because of the risk of arterial vasospasm.
So let's say a patient comes in with a cluster headache attack. What's the first thing you reach for?
Oxygen is usually my go-to. It tends to be the most effective and has the fewest side effects for most people. If I can't use oxygen, maybe it's not available, or the patient can't tolerate it for some reason, then I'd probably go with subcutaneous sumatriptan.
Now let's talk about medications we can use between those acute attacks to try and prevent them from happening in the first place.
One option is prednisone. It's a good short-term bridge between acute attacks and starting preventive therapy.
What does a typical prednisone regimen look like?
I usually start with oral prednisone at 100 milligrams per day for 5 days, and then I taper it down by 20 milligrams every 3 days, and I often combine this with verapamil. But it's really important to remember that using prednisone repeatedly can have side effects like osteonecrosis.
Occipital nerve blocks are sometimes used in this period between attacks too. What can you tell us about those?
Occipital nerve blocks have actually been shown to prevent cluster headaches from happening, and they seem to be safe for repeated use in both episodic and chronic cases. One study found that the median time between injections was 100 days. But there is a downside. Roughly 40% of patients do experience side effects. There was this study that showed patients with chronic cluster headache only reported a median relief duration of 3 months, which isn't that long. Interestingly, though, patients who hadn't had cluster headaches for as long seemed to respond better.
So they might provide longer relief for some patients than just treating the acute attack, but they do come with their own set of issues. Are there any other things that make it hard to interpret the data on occipital nerve blocks?
One thing is that a lot of the studies are quite small, and there isn't a standard definition of what a good response actually is. And then on top of that, the studies often use different agents and doses, which makes it hard to compare them directly.
Makes sense. All right, let's move on to preventive treatments for cluster headaches.
Verapamil is generally the first-line preventative medication, although it's worth noting that both the FDA and the EMA, the European Medicines Agency, haven't officially approved it for this use.
If it's not officially approved, why is it the go-to choice?
Well, even though it doesn't have that formal FDA approval, it's got a good track record, it works in practice, verapamil basically stops calcium from getting into cells. And this seems to lower the release of calcitonin gene-related peptide, reduce the excitability of hypothalamic pathways, and actually even help regulate the circadian rhythm.
What's the typical dosage for verapamil?
We start with 80 milligrams 3 times a day, and then depending on how well the patient tolerates it, we increase the dose by 120 milligrams every 14 days. The maximum daily dose can go all the way up to 960 milligrams to get the full preventive benefit.
With doses that high, what kind of side effects should neurologists be looking out for?
One thing to watch for is cardiac conduction abnormalities, particularly something called prolongation of the PR interval on an electrocardiogram. So regular ECG monitoring is a must, especially once the dose goes above 480 milligrams per day. In fact, it's a good idea to get a baseline ECG before you even start treatment to rule out any pre-existing cardiac arrhythmias. Other common side effects are constipation, swelling in the ankles, and gingival hyperplasia. That's overgrowth of the gum tissue.
So it's an effective preventive treatment, but it needs to be used carefully and with close monitoring. Let's talk about some of the other preventive options. One of the newer ones is galcanezumab. How does that one work, and what kind of results are you seeing with it?
Galcanezumab is a humanized monoclonal antibody, and it targets calcitonin gene-related peptide, or CGRP. It blocks this ligand, so it can't bind to its receptor, and that ends up inhibiting vasodilation. This was actually the first treatment specifically designed for cluster headaches.
How is galcanezumab given?
It's given as a subcutaneous injection. Typically, the dose is 300 milligrams, which is 3 100 milligram injections, all given at the same time. This is done when the cluster period starts. After that, it's given monthly until the end of that cluster period.
So it's not a daily medication. That's got to be a big plus for patients.
It is, and studies have shown that it can reduce how many attacks patients have each week, at least for episodic cluster headaches. Unfortunately, trials in patients with chronic cluster headache weren't successful. It's also worth noting that it may be helpful for those patients who get both cluster headaches and migraines.
What about long-term use? Any safety concerns there?
Follow-up trials, both for chronic and episodic cluster headaches, have shown that it's safe and well tolerated in the long run.
That's good to hear. Now let's talk about onabotulinum toxin, or Botox. Does that have a place in preventing cluster headaches?
Well, the evidence for Botox in cluster headaches isn't quite as strong as it is for migraines, but there are some positive findings.
Can you explain how Botox works when it comes to headaches?
It basically breaks down this protein called SNAP225, which in turn stops neurotransmitters from being released, including the ones involved in sending pain signals. This is thought to reduce both the frequency and how bad the attacks are.
What's the typical injection protocol for cluster headaches?
We use the pre-MP2 protocol, which involves giving between 31 and 39 injections targeting 7 specific muscle areas. The total dose ranges from 155 to 195 units and is adjusted based on how well the patient responds.
So what have the studies actually shown about how well Botox works for cluster headaches?
The results are a bit mixed. Some studies show that it can reduce the frequency and severity of attacks in chronic cluster headache, but it's less clear whether it really helps with episodic cluster headache.
So more research is needed there. Is there anything new on the horizon with Botox?
There's a new technique that involves injecting Botox directly into the sphenopalatine ganglion. It's still early, but the results from small studies have been pretty promising.
Another older medication sometimes used is lithium carbonate. Why use lithium for this, and how well does it work?
Well, lithiums have been around for decades, and the thinking is that it stabilizes the activity of neurons and helps regulate the circadian rhythm. But the evidence for its effectiveness in cluster headaches is a bit thin.
What's the usual lithium dosing regimen?
We usually start with 300 milligrams per day, and then we adjust the dose based on the patient's lithium levels. The maintenance dose usually ends up somewhere between 900 and 1200 milligrams per day.
It sounds like lithium could be a good option if other treatments haven't worked, but what are the potential downsides?
A big concern with lithium is that its therapeutic window is very narrow. That means there's not much difference between a dose that works and a dose that's toxic. So it's crucial to monitor plasma lithium levels very closely and to regularly check kidney, liver, and thyroid function. And if you're using lithium with verapamil, you have to be extra careful because verapamil can actually increase the risk of lithium toxicity.
So close monitoring is key with lithium. What are some of the common side effects?
The common ones are tremors, increased urination, weight gain, and feeling mentally foggy.
That's quite a few potential side effects. Are there any other preventive treatments neurologists should know about?
Yeah, actually, a couple of anti-epileptic drugs are sometimes used as a second or third line option.
Anti-epileptics for cluster headaches. How does that work?
Well, they can change the levels of certain neurotransmitters and how excitable the neurons are, and this can have an effect on the pathways involved in headaches. Topiramate, for example, blocks sodium channels, glutamate receptors, and boosts the activity of GABA, which is an inhibitory neurotransmitter. It's got a lot of different actions, and that may be why it helps some people with cluster headaches.
How do you dose topiramate?
We usually begin with 25 milligrams per day, and then we titrate it up weekly in 25 milligram increments, going up to a maximum of 100 milligrams per day, given in 2 divided doses.
Any contraindications or things to be especially cautious about with topiramate?
It's definitely contraindicated in pregnancy because it can cause birth defects. It's also not a good choice for patients with kidney stones. And we always have to be mindful of the possibility of cognitive problems and suicidal thoughts with topiramate.
So topiramate can be an option, but definitely needs to be used carefully. What about Valproate?
The evidence for Valproate is a bit mixed. Some studies have shown benefits, but others haven't. The typical dose is between 5 and 20 milligrams per kilogram of body weight per day.
Sounds like we still have a lot to learn about Valproate for cluster headaches. Now,
Yeah.
What about melatonin? Does that play a role in preventing cluster headaches?
Melatonin can be a really helpful add-on therapy, especially for those patients who just can't tolerate other preventative treatments. We know that patients with cluster headaches tend to have low melatonin levels both during and in between their bouts, and melatonin is super important for regulating the circadian rhythm. So the idea is that by supplementing with melatonin, we can help restore that balance.
What doses of melatonin do you use for cluster headaches?
Studies have shown that high doses, like 10 milligrams, can reduce how often attacks happen in the early days of a cluster period in people with episodic cluster headache.
So it's not a cure, but it can be a helpful tool, especially at the start of a cluster period.
Yeah.
What are the advantages of using melatonin?
Well, it's very safe and well tolerated, which makes it a great choice for patients who are sensitive to the side effects of other medications.
So we've covered a lot of ground on acute and preventative medications. Let's talk about neuromodulation. What are the options there?
Non-invasive vagal nerve stimulation, or NVNS, is a pretty exciting new development. It involves delivering electrical impulses to the vagus nerve through the skin, usually on the neck. This way, we can change the nerve activity without having to do surgery.
What kind of results are we seeing with NVNS for cluster headaches?
Studies have shown that it can reduce how often attacks happen, provide pain relief, and even stop an attack altogether. It might even help reduce the need for acute medications in patients with episodic cluster headache.
Is there a specific NVNS device you usually recommend to your patients?
Nice, Steve. The National Institute for Health and Care Excellence has said that the GammaCore device is safe to use for treating cluster headaches.
And how effective is GammaCore? How is it usually used?
Around 40% of patients respond well in the first month, but that drops to less than 30% in the following months. For prevention, we recommend patients use it twice a day, once an hour after waking up, and then again at night with two-minute stimulations each time. For acute treatment, the patient does two-minute stimulations as soon as the pain starts, and they can repeat that as needed.
Are there any other types of nerve stimulation that are showing promise for cluster headaches?
Percutaneous occipital nerve stimulation has shown good efficacy and tolerability in patients with chronic cluster headache, especially those cases that are really tough to treat with medications alone.
How does percutaneous occipital nerve stimulation work?
It involves stimulating the occipital nerves, which are at the back of the head. We do this with electrical impulses that are delivered through needles placed through the skin. It's been shown to affect the pain signals going to the brain, which helps reduce how often cluster headaches happen and how severe they are.
Okay, so we've talked about various medications and neuromodulation approaches. What about invasive procedures?
Invasive or surgical procedures are really reserved for those patients with severe and intractable cluster headaches, the ones that just haven't responded to anything else. They do carry risks, so we have to be very careful about using them.
Can you tell us a little more about these last resort options?
One is sphenopalatine ganglion stimulation. It involves implanting a neurostimulator near the sphenopalatine ganglion, which is a group of nerve cells deep in the face. The stimulator is turned on when an attack starts. It's a complicated procedure, but it can be life-changing for some patients.
What kind of evidence do we have for its effectiveness?
About 70% of patients with chronic cluster headache who haven't responded to other treatments get significant pain relief with sphenopalatine ganglion stimulation. It's actually 10 times better at relieving pain than a placebo. Some patients even become completely pain-free within 15 minutes of turning it on. The best part is that the benefits seem to last. 2/3 of patients are still reporting relief after 2 years.
It sounds like sphenopalatine ganglion stimulation can make a huge difference for people who have these debilitating cluster headaches. Are there any serious risks with the procedure?
It's generally pretty safe. Some patients have temporary sensory disturbances after the implant is put in, but these usually go away within a few months.
What about occipital nerve stimulation? How does that compare to sphenopalatine ganglion stimulation?
It's a bit different. We implant electrodes near the occipital nerves, similar to the percutaneous approach, but in this case, the electrodes are connected to a generator that's implanted under the skin. This generator sends out continuous electrical pulses. It's also been shown to reduce the number of attacks each week and provide good pain relief.
Are there any downsides to occipital nerve stimulation?
Well, there's a risk that the leads could move or the battery could fail, and that would mean another surgery.
Are there any other invasive procedures you might consider for those really tough cases?
Pulsed radiofrequency therapy, which targets the sphenopalatine ganglion using CT guidance, has shown some promise in making the remissions last longer, particularly when it's combined with steroids. Then there's deep brain stimulation, or DBS, which involves implanting electrodes in the hypothalamus.
Deep brain stimulation, that sounds pretty intense. What have the studies shown about its effectiveness for cluster headaches?
DBS has been shown to reduce pain significantly in some studies, but there are potential adverse effects that we have to consider.
So it's really only for the most severe cases where nothing else has worked. Now, how does managing cluster headaches change when you're treating specific populations like children or pregnant women?
Treating cluster headaches in children and pregnant women comes with its own unique set of challenges. Let's start with kids. One of the biggest issues is that it's often misdiagnosed. The symptoms can be less severe and less frequent than in adults, so it's easily missed.
What makes it so tricky to diagnose in children?
Well, they tend to have fewer of those autonomic symptoms, their attacks don't happen as often, and their remission periods are longer, which can make it easy to overlook.
So it might get mistaken for migraines or other types of headaches. Are there any set guidelines for how to treat cluster headaches in children?
Unfortunately, there aren't any established guidelines or controlled trials that tell us exactly what to do for kids with cluster headaches. We have to rely on what we know from treating adults and use our best judgment.
So it's more of a guessing game when it comes to treating kids with cluster headaches. What sorts of treatments do you usually consider for them?
For acute attacks, I often start with oxygen or intranasal sumatriptan as the first-line options. For prevention, I tend to favor a verapamil, but I might also think about melatonin, gabapentin, tocoramate, valproic acid, or indomethacin. Similar to adults, greater occipital nerve injections can be considered for children.
It sounds like there's a lot more we don't know when it comes to treating kids with cluster headaches. What about pregnant women? How does pregnancy change how we manage cluster headaches?
The biggest thing is making sure we're protecting both the mother and the baby. Whenever possible, I try to avoid medications and focus on non-pharmacological approaches. But if medications are absolutely necessary, we have to carefully weigh the risks and benefits and pick the safest ones possible.
So options like high-flow oxygen, short courses of corticosteroids, and single greater occipital nerve blocks are generally considered safe.
They are, but it's still important to assess each situation individually and talk to the patient about the risks and benefits. It's also really important to work closely with the patient's obstetrician and any maternal fetal medicine specialist involved in their care.
It sounds like managing cluster headaches in pregnant women is a real balancing act. Before we move on to the newer treatments, is there anything else neurologists should keep in mind when treating these patients?
It's crucial to remember that cluster headaches can have a significant impact on patients' mental health. We know that anxiety, depression, and even suicidal thoughts are common.
So taking care of their mental health is just as important as managing their pain.
Absolutely. I always try to take a whole person approach. I make sure to offer support and resources, and if needed, I refer patients to a counselor or psychiatrist.
That's so important. It's easy to focus on the physical symptoms of cluster headaches, but we can't forget the emotional toll it takes on patients. Now, let's shift gears and talk about some of the new and upcoming treatments that offer hope for the future.
There are some promising new drugs in the pipeline.
Can you give us a sneak peek at what's coming?
One drug that's generating a lot of interest is lasmiditan. It's a 5-HT1F receptor antagonist.
What's special about the 5-HT1F receptor, and why is everyone so excited about lasmiditan?
Well, preclinical studies suggest that it might be a new way to treat cluster headaches, and it might be a safer option for patients with vascular risk factors who can't tolerate other treatments like triptans.
So it could potentially expand our treatment options, especially for patients with certain risk factors. What other new medications are being studied?
Ketamine, which is an NMDA receptor antagonist, is another drug that's being investigated for its potential to treat cluster headaches.
Why ketamine for cluster headaches?
Ketamine has already been successful in treating other types of chronic pain, and we think it works by affecting central sensitization. That means it changes how the brain processes pain signals.
So instead of targeting the headache directly, ketamine could actually change how the brain perceives pain. Are there any trials going on right now that are looking at ketamine for cluster headaches?
Yes, there are ongoing trials using both intranasal ketamine spray and intravenous ketamine infusions for chronic cluster headache. However, we have to be careful with ketamine because there's a potential for abuse, so it's important to monitor patients closely and make sure we're choosing the right patients for this treatment.
Safety always comes first. What other new pharmacological approaches are being investigated?
There's a lot of interest in oral CGRP antagonists, like rimegepant. We already know that rimegepant works well for treating migraines, and researchers are hopeful it might be helpful for cluster headaches, too.
So are oral CGRP antagonists basically trying to do the same thing as the injectable CGRP monoclonal antibodies, but in a more convenient way, a pill instead of an injection?
That's the idea. And there are ongoing trials looking at the long-term use of other CGRP monoclonal antibodies, like eptinezumab and erinumab, for chronic cluster headache.
It sounds like there's a lot of research going on around CGRP as a target for treating cluster headaches. Are there any other promising targets on the horizon?
PACAP38 is another neuropeptide that's similar to CGRP, and it's emerging as a potential new target. Early research suggests that blocking PACAP38 might be an effective way to treat cluster headaches.
So both PACAP38 and CGRP are in the same neuropeptide pathway and could be potential targets for new treatments. What about non-pharmacological treatments? Anything new happening in that area?
There are trials underway that are exploring new ways to use existing techniques. One is looking at whether repeated greater occipital nerve injections with methylprednisolone could be a preventative treatment for chronic cluster headache. Another one is studying the use of Botox injections directly into the sphenopalatine ganglion for chronic cluster headache.
So researchers are trying to refine the techniques we already have and target those key areas we've talked about. Are there any other completely new and innovative therapies in development?
There's been a surge of interest in using psychedelics for cluster headaches.
Psychedelics. You mean like LSD and psilocybin?
Exactly. There's early evidence, mainly from case series and patient surveys, that suggests they might be able to help people with cluster headaches.
That's fascinating. How could psychedelics possibly help with cluster headaches?
We don't know the exact mechanisms yet, but we think it might have something to do with how they affect serotonin receptors, especially the 5-HT2A receptor. They might also play a role in what's called the arresting pathway, which could disrupt the cycle of cluster headaches.
It's really interesting to think about psychedelics potentially interrupting the cluster headache cycle. Is there any real evidence to support these anecdotal reports?
A recent study showed that giving a repeat dose of psilocybin actually resulted in a significant 50% reduction in how often cluster attacks happened. And this was during the blinded extension phase of a randomized controlled trial, which means it was a well-designed study. There's also a trial going on right now that's investigating the effects of oral LSD on both episodic and chronic cluster headaches.
It's still early, but it's definitely an exciting area of research. It's encouraging to see so much progress being made in finding new and better treatments for cluster headaches. We've covered a lot of information today, from the basics of diagnosis and what causes them to all sorts of current and future treatments.
It's clear that research in cluster headaches is moving quickly, and new and more effective treatments are on the horizon.
I think that's a great place to pause for now. We've given our listeners plenty to think about.
That was a really thorough overview of all the treatment options available for cluster headaches. It's important to remember, though, that what we've discussed is really just a brief summary of the research.
That's a great point. It's always best to go to the source, to read those full articles, to get the complete picture, and to make sure you're up to date on the latest guidelines and research.
Now, let's shift gears a bit and talk about how our listeners can put all of this knowledge into practice.
What are the key things neurologists need to be thinking about when they see a patient who might have cluster headaches? What are the red flags, those telltale signs that this is what we're dealing with?
The first thing is to make sure we're not mistaking it for something else, something that looks like cluster headache but isn't. We see this a lot, especially with children and women.
So taking a really detailed history is essential.
Definitely. Asking detailed questions about what their headaches feel like, when they happen, any other symptoms that come along with them, and if there's anything that seems to trigger them.
And, of course, doing a thorough neurological exam.
Absolutely, to rule out any other possible causes.
What are some of the other conditions that can mimic cluster headache, the ones that neurologists should be on the lookout for?
Migraines are a common one, especially in kids. Other things that can present similarly include other trigeminal autonomic cephalalgias, trigeminal neuralgia, and trigeminal neuropathy. And of course, we always have to think about secondary headaches, the ones caused by underlying problems like structural lesions or infections.
So it's really a process of elimination, carefully considering all these other possibilities and ruling them out before we can say for sure that it's cluster headache.
That's right. And once we've made the diagnosis, we need to figure out if it's episodic or chronic cluster headache. That will really guide our treatment strategy.
Once you've diagnosed someone with cluster headache, how do you go about choosing the best treatment? What factors do you weigh?
Every patient is unique, so treatment has to be individualized. I always think about the patient's age, their overall health, how bad their attacks are, and how often they have them, how well they responded to treatments in the past, what they prefer, and of course, how well they tolerate side effects.
So it's a conversation, a collaboration, working with the patient to figure out what's going to work best for their specific situation.
That's a great way to put it. Shared decision-making is crucial in cluster headache management. And it's not just a one-time thing. We need to keep checking in, see how they're doing, and adjust the treatment plan as needed. Things change. Patients might develop side effects or build up a tolerance, so we have to stay flexible.
Let's get into the nitty-gritty of managing acute attacks. What do you do when a patient comes in or calls while they're in the middle of a cluster headache?
As we talked about earlier, high-flow oxygen therapy is still the most effective acute treatment. It's safe, it works, and it's usually pretty easy to get a hold of. Subcutaneous sumatriptan is another good option, especially if you can't get oxygen quickly, or the patient would rather have something they can carry with them.
Do you ever use those other acute treatments we discussed, like the intranasal triptans or dihydroergotamine?
I might consider them in certain cases, but remember that intranasal triptans tend to be slower acting and dihydroergotamine comes with more risks, and some patients can't take it at all. It's always a balancing act, weighing the potential benefits against the risks for each individual patient.
Once the acute attack is under control, how do you go about preventing future episodes? What's your go-to strategy?
Verapamil is usually my first choice for prevention, but as we discussed, it's not perfect. It's really important to monitor patients for heart-related side effects, and some patients just can't handle the high doses that are needed to prevent their attacks.
What are your other options if verapamil isn't a good fit? Maybe it's causing too many side effects or it's just not doing the trick.
Galcanezumab is a good option for episodic cluster headaches. Many patients like that, it's just a monthly injection. But we have to remember that it hasn't been shown to be helpful for chronic cluster headache. And then there's Botox injections, lithium, topiramate, and melatonin. Each has its own place, and we have to consider the individual patient to decide which is best.
It's also important to remember those non-pharmacological strategies, right?
Absolutely. Encouraging patients to learn what their triggers are and avoid them, getting enough sleep, and just generally having healthy lifestyle habits can really make a difference in how often they have attacks.
So it's about taking a multi-pronged approach, addressing both the biological and behavioral aspects of cluster headache. And for those patients with really tough-to-treat cluster headaches, neuromodulation techniques and surgical procedures can be a last resort.
They really do offer hope for those patients who have tried everything else and haven't found relief.
Speaking of trying things, how do you monitor patients on these various treatments? What are the key things you're keeping an eye on?
For anyone on verapamil, I always get regular ECGs to check for any problems with their heart rhythm. For patients taking lithium, it's essential to monitor their lithium levels very closely to make sure they're within that safe range and not getting toxic. And of course, I always watch out for potential side effects from any medications they're taking.
It's about being proactive, right? Anticipating potential problems and keeping a close eye on patients to make sure they're safe and getting the best possible outcome.
Exactly. And as we've talked about, it's also really important to pay attention to how cluster headaches are affecting patients' mental health.
It's a really tough condition, and we know that many patients struggle with things like anxiety, depression, and even thoughts of suicide.
I always address those issues directly. I offer support, connect them with resources, and if needed, refer them for counseling or to see a psychiatrist. It's all part of providing comprehensive care for these patients.
That's a crucial point. It's not just about treating the physical pain, it's about taking care of the whole person. Let's go back to those specific populations we talked about before. What advice do you have for neurologists who are managing cluster headaches in children and pregnant women?
When it comes to kids, the key is to always be suspicious. Don't just assume that recurring headaches are migraines, especially if there are any signs of autonomic involvement. Remember that we have fewer treatment options for children and the evidence isn't as strong. It's often a good idea to consult with pediatric neurologists and headache specialists in these cases.
What about managing cluster headache in pregnant women? What are the most important things to keep in mind?
The top priority is the well-being of both the mother and the baby. Whenever possible, I try to avoid medications and focus on lifestyle changes and other non-drug approaches. If we absolutely have to use medications, we have to be extra careful about the risks and benefits and choose the ones with the best safety profiles.
So things like high-flow oxygen, short courses of corticosteroids, and single greater occipital nerve blocks are usually okay.
Yes, but it's important to evaluate each patient individually and talk to them about the risks and benefits. And close communication with the patient's obstetrician and any maternal fetal medicine specialists involved is crucial.
Before we wrap up, I'm curious to hear your thoughts on what the future holds for cluster headache treatment. What are you most excited about? Where do you see the field going in the next few years?
The progress we've made with CGRP monoclonal antibodies is really exciting. They've been a game changer for so many patients with episodic cluster headache, and I'm very optimistic that the research that's happening now will lead to effective treatments for chronic cluster headache too. The research on PACAP38 as a target is also very promising.
The potential of neuromodulation and even psychedelics is fascinating to think about. Imagine if we could interrupt the cluster headache cycle and provide long-term relief with minimal side effects.
It's a great time to be working in this field. Even though we don't have a cure for cluster headaches yet, I'm confident that with continued research and collaboration, we can keep making life better for our patients.
I totally agree. And as we wrap up this part of our deep dive, I want to remind everyone that this is just a summary of a single review article.
Our listeners should definitely read the full article and keep up with the latest research and guidelines.
That's a great point to end on. We've talked about a whole lot of treatments for cluster headaches, everything from managing acute attacks to preventing them from happening in the first place.
It's a really complex condition, and there's no magic bullet, no one-size-fits-all solution. The key is finding what works best for each individual patient.
Absolutely. As we wrap up this deep dive, what are your main takeaways from all the research and information we've discussed?
I think the progress we've made in recent years with the CGRP monoclonal antibodies is pretty remarkable. They've really changed the game for a lot of people with episodic cluster headaches, giving them new hope where there weren't many options before. We still need more research to figure out how well they work for chronic cluster headaches, but the advancements we've seen so far show us just how much potential there is for even more innovative therapies in the future.
The research on PACAP38 as a potential treatment target is also very exciting.
It definitely is. It could lead to new treatments that specifically target another key neuropeptide involved in those cluster headache pathways.
We've come a long way in how we understand and treat cluster headaches.
And with continued research and collaboration, I'm confident we can make even bigger strides in improving the lives of people living with this condition.
I couldn't agree more. It's been a fascinating discussion. And to our listeners, thank you for joining us on this episode of Weekly Neurology Deep Dive. We'll be back next week with another deep dive into the latest neurological research. Until then, keep learning and stay curious.